Yeah, hi. Is my screen visible? Beam, are you there? Srijana, Beam, who's there?
Sir, not visible, sir.
It is visible on the live feed. I can see it. I can see it on Facebook Live. It's already live.
Okay, sir. Yes, sir.
Hi, good evening, good afternoon, everyone. Welcome to NEET 2022 Recall Cardiology session. And after a wonderful session that Dr. Rahul Rajiv did yesterday for the approach, I'm just going to add a couple of things that I felt as a faculty from the cardiology perspective, and we'll discuss the questions. Just the right answers. I'm not going to take the topic in detail, the whole detailed video if required. We will upload it on the app. But this is here primarily to recall the question and also to discuss what were the possible options and what is possible correct answer if the recall of the question framing is correct. So even if we assume that people, I mean, the feedback that I got from most of my students was that this was relatively a tougher paper compared to the last year. A lot of questions were just the remembering the points, and the framing of the question were primarily on not conceptual but on factual. So there were facts that were asked primarily, and a lot of questions were based on true or false kind of a format. If you know the answer, you know it, otherwise you don't. So it's slightly tougher paper compared to what was anticipated over the years with a clinical scenario being given, but still you had a lot of images, and all of them primarily were coming from cardiology or neurology. So that was the on the cardiology perspective, I would say a lot of cardiology was still there. People were initially telling me that the cardiology neurology was asked less, but when I analyzed the paper, actually there were 25 questions that you can overlap between cardiology or a non-cardiology. For example, there was a question on high altitude pulmonary edema, and the answer was nifedipine. So nifedipine is a cardiovascular drug. You can call it a cardiovascular question, but though of course it can qualify as a high altitude pulmonary edema, not being a question there. So I'm open to your comments. You can. I'm also there on the. We are there on the YouTube live. So if there are any questions, we'll be happy to answer them as well. So I'll take you through now the important questions that were there. I'll try to create an image that was probably we can get, or because we don't have an access to the images that were there, but I'll try to mimic them and try to put images that may have been there. So I'll go through those 25 potential questions. 20 questions were definitely there. So if you were to count out of 150, 25, that is 1/6 was still cardiology. So cardiology, I believe, was amongst the different subgroups, though there were a lot of genetics, but they did not exceed the number of questions in cardiology. And so I feel you cannot overlook, or cardiology continues to be a predominant subject that is still being weighing heavily, even though initial perception was, and the feedback that I got, that people were telling that cardiology neurology was less. I don't think so, because if you were to decide between so many branches, you will have to weigh and create a paper in a format that includes all the subspecialties. And despite that, cardiology has, I believe, dominated in the question framing. So we'll go through, and I'll try to take you from the recall from the friends and the students like you who've been sharing the questions and the potential options. I may not have all options to the questions, but that's not the idea, because I don't want to confuse you with the wrong options. I'm going to tell you what is the factual answer for that question, if that is how the question was asked. So let's start with a couple of images. And this was the image I was told. This was an image, and there was no doubt about this on a lot of people's mind, that primarily it was an image of RBBB LAHB. And that's why I think I've cropped up an image which shows the RBBB LHB. So there is the right bundle branch will appear like RSR dash in V1, and LAHB would be small r and big S in inferior lead. So that's how the left anterior vesicle looks like. So you have a right bundle branch block, and you have a left hemifascicular block. So this is another image taken from there, though you can discreetly say in this image the P waves abnormality is also there, but this is not the classical image that was put there. The people have been telling me that there was a classical RBBB LAHB which was put. So I'm not going through the other options for this, but the second image people were saying were 2:1 AV block, because image can't be recollected or recalled per se. And you can see what you anticipate is 2 P waves followed by 1 QRS. And that's how it is. There is a regularity and the PR interval is not prolonged. So you have a normal PR interval, and every P is after every second P there is a QRS. So you have 1 P wave, a QRS, a P, and there is a QRS drop, and another P and a QRS, and P and QRS is dropped. So this is 2:1 AV block. These two were classical images that I believe everybody got right. And that's the good aspect of images being not so tough. We were preparing you all this time for multiple other images, including the intervention images like the coronary images that we did in the recall session. In the QRP session, we also did a couple of images in the IVUS, OCT, etc. in the test series that we prepared for you. So we were preparing you for them, but primarily they've stick to X-rays and ECG only, and that's probably a good part. The other image that was there was of a RV lead ECG, I was told, and there was inferior wall MI with RVMI. So there is 2-3 AVF elevation, and there is AV elevation in the right-sided leads, which is V2, V3, and V4. The patients who come with this kind of a presentation, the options that were given were all the management strategies of lysis and dual antiplatelets, but all were true except one question of the option that was given was restriction of fluid. Now remember, RV is a volume dependent structure, especially it's a volume sensitive structure, and when there is RV dysfunction, you would actually want the RV to contract more and work at its peak of the Frank-Starling curve. You want to increase the preload of RV so that at least cardiac output is maintained, and increasing the RVDP, you can actually probably attain that and also have maintained the hypotension being treated because of the RVMI. And that's why restriction of fluid is a wrong option, and hence the amongst the options given. So all were true except restriction of fluid is incorrect, is not to be done in patients with inferior wall with RVMI. These patients actually require IV fluid. So treatment of inferior wall MI, RVMI is IV fluid. Hari Prasad and Saurabh Mishra are asking history of giddiness in an elderly male. That's how the question was framed for the previous CCG. And Hari Prasad is also asking how to differentiate with complete heart block for the question number 2. I'll go back there. So for complete heart block, there has to be AV dissociation. What you look at in AV dissociation is that the P wave will run at its own pace, which here it is running, but the QRS should not be having any fixed relationship with the P wave. So if there is no fixed relationship, I had shown one ECG in the spotters, if you remember, which was a narrow complex ECG. And in the spotter lecture that we had shown a narrow QRS complex, but a complete heart block. So the P wave and the QRS were dissociated. They were running independently. They were not having any relationship between them. That's how, Hari Prasad, we differentiate 2:1 block from the patients with complete heart block. So again, the ECG, what Dr. Hari Prasad's input is that the QRS was a bit broad in the 2:1 AV block in ECG question. So if you had AV dissociation, it can be complete heart block. But if there was AV synchrony maintained for every 2 P wave, the QRS is dropped, then it remains a 2:1 AV block. Other options, what Dr. Garvit Mundra is sharing is the in this question number 3 of inferior with RVMI was the PCI, thrombolysis, and aspirin. Those were the 4 options, so there is no controversy about it. You can do a primary PCI, you can give aspirin, and you can thrombolyze, but you don't restrict fluid in a patient who's come with inferior wall RVMI. Thank you, Garvit, for the other 3 options, but I've deliberately not chosen to, pursue and try to dig out the other options because I don't want to be distracted by them. I want you to know the answers right now. That's the whole idea. But thank you, Garvit, for sharing the option. So the question was framed as Ayub Vani is sharing is not in this fashion. It was which of them is of minimum use for RCA ACS. So you have inferior wall RVMI, which is the least likely or least supportive strategy. That's how the question was, or rather than all true or except. So the framing may be different. The concept around the question was acute inferior wall with RVMI. What you don't do is restrict the fluid. You actually push the fluid. Of course, dual antiplatelets, thrombolysis, primary PCI do remain important strategies in managing. Thank you, Ayub, for your important feedback on the same. Question number 4 was tendon rupture, potential side effect of which drug? Now, there are two important drugs that come to your mind. One was steroids, another statin. There was some confusion. Some of the students mentioned in the recall that the steroid was an option, but then a lot of people countered it and they said steroid was not given as an option. The steroid was not given an option. The other option that would come as the potential side effect of a drug which causes tendon rupture, it is statin. So there are papers and there are a lot of reported cases of statins being associated with not only tendinopathies or tendon rupture, especially the tendons that rupture is Achilles heel, quadriceps, biceps tendons. And this occur usually within actually not the chronic usage, but in the first year itself. So these are probably, there might be genetic linkages to the same patients who are more prone to develop these side effects. And hence these subgroup of patients, they can develop statin in associated tendonitis or tendon rupture, which was the question number 4 that was asked. The fourth question that we people could recall. Other options were HCQS, chronic heparin, and I think biphosphonates. Right, Saurabh? Thank you for sharing the options. Chronic heparin does not cause tendonitis. Statins do. HCQ, no, it can cause myopathy, but not tendon rupture. And the other option, bisphosphonates also don't cause tendon rupture. Only in the hyperparathyroidism, on the contrary, if you don't use them, patients can actually develop tendon rupture. Bisphosphonates would actually prevent it in that disorder if it's the case. So statin remains the answer for this question, which was recalled by a lot of you students. Thank you for sharing your inputs in the group, and that's how we could frame it. Now, question 5, there was some confusion because of metformin's UKPDS data. But remember, when you're talking about this kind of a framework of a question, this is an absolute cardiology question. This is a question that a cardiologist would be very keen to frame rather than a diabetologist. Patient was a hypertensive diabetic, post-MI, post-stenting. And patient is a CKD, EGFR 58, already on ACE inhibitor, which is enalapril, atorvastatin, aspirin, and clopidogrel. So which is the most cardioprotective effect? There's no doubt this question answer has to be empagliflozin, because this is the classical candidate or inclusion criteria of EMPA-REG outcome study. In EMPA-REG outcome study, most of the patients were patients who had were secondary prevention patients. And we have discussed this in our management of heart failure lecture also. We have discussed this also in the 4 pillars of heart failure management. We have discussed this also in our videos in cardiology and the late breaking trials, which I discussed in the WhatsApp groups also. The EMPA-REG outcome was the trial that not only reduced all-cause death, but also absolutely also, but CV mortality. So metformin in UKPDS did not reduce these as individual parameters. It did reduce overall, but then this classical case scenario, which is given here, is a classical inclusion criteria of EMPA-REG outcome, which showed. And of course, nephroprotection is the other thing which could have been asked. And then again, probably you would have gone with another gliflozin, maybe DAPA, and now you have data for the EMPA also. But DAPA CKD trial, if this question was reframed, which is the nephroprotective agent, again, the answer would not be metformin. It would still come out to be a gliflozin, an SGLT2. So I hope that clears the doubt about metformin and empagliflozin. One of the students actually shared, said, why not pioglitazone? A couple of reasons. One, patient, we don't know the LV dysfunction thing, but then remember, most of the data for pioglitazone in IRIS trial comes from the establishment of CVD. So post ASCVD, glitazones don't have data. Glitazones in the IRIS data was primarily for pre-diabetic or patients who still had not developed a disease. So the patients who already developed disease, the answer has to be empagliflozin. So that clears, I hope, all the doubts around this question. Another question that was asked on, and as I always used to say, most of our questions would you need to focus very strongly. If you remember our two QRP sessions we did, one of the key QRP was heavily based on your clinical aspects. We did the waveform analysis, we did the heart sound analysis, we did discuss the splitting. And this is again from our QRP session. This question was from our QRP, if you remember, a splitting of second heart sound. That's where I had revised this thing. When you have a severe aortic stenosis, it's not the thrill nor the murmur. Length of the murmur does differentiate. Grade or the severity or the intensity does not. Remember, even in aortic sclerosis, you can get a loud murmur. Murmur can radiate to the carotids depending on the turbulence. What is the most important feature? More severe the stenosis, more will be the delay in the A2, more will be the ejection time from the left ventricle. More is the ejection time because of the obstruction, more will be the delayed closure of the second heart sound. And hence this would lead to a paradoxical split. So if a patient has got paradoxical split, you are dealing with a severe AS. So amongst the criteria or amongst the 4 options that were given for which were suggestive of severe aortic stenosis, between these, you will have to choose paradoxical split or single S2. Carotid thrill or intensity of the murmur does not tell you severe AS. So I hope that is correct. That is clear to all of you. The answer in the current scenario would be paradoxical split or single second heart sound. There were a couple of questions on JVP. You remember there is a free session that DocTutorials provides for JVP. If you go and download DocTutorials app, my 2 lectures are free. One of them is on JVP, and the purpose of making and my requesting DocTutorials and they accepting this, my request of making JVP as a free lecture, is because I know it's such an important question and a session and the topic that most of the times, at least a couple of questions will come from JVP. And that's the whole idea, because our idea is to let this knowledge percolate all across to all of you. So JVP session, you can go and see. It's a free session available, free video, which is available in the app. And 2 questions, actually. Some people say there were 3. We can touch upon the 3rd one later on. But the 2 important questions was TS and TR. So one was tricuspid stenosis. And as you know, if there is tricuspid valve is narrowed, the time that it will take, the way it will open and descend would be slow. And hence, what is reflective of descent of the opening of the tricuspid valve? It is the Y wave. So Y wave corresponds with the what you call as S3. Y wave also corresponds with the opening of the tricuspid valve and the filling of the ventricle. Because tricuspid valve is narrowed, and hence the opening would be slower, and thus would reflect in the slow Y descent. So there is, I mean, the other options, whatever they were, there was one recollection of C wave and A wave, but I think we need to remember that what is most classical is slow Y descent, and that's the finding that you would go with the answer and the option in this question scenario. Similarly, in a patient who's got tricuspid regurgitation, I believe giant S wave was not given, but the TR would be reflected by the contraction of the RV and then filling up of the RA. And this would go with the C. So C for C, that's how you remember. That's what my lecture tells you. C stands for contraction. C stands for carotid. Carotid means the carotid pulse. That's which, again, you can remember C for contraction of the ventricle. And that's why when the ventricle is contracting, the wave that you get is C. If the blood leaks into the RA, what you will get is the prominence of the C. So again, if you go through my free lecture on the app, you can see that the CV waves, which if they become too big because of the severe TR, they are also called as giant S wave. And that's why obliterated X and CV complex together is called giant S. And that's the finding in a patient with severe TR. Again, I have not even mentioned the other option. So Ayub Wani is saying that the RCACS, which of the following is least useful, was the question. Yes, Ayub, we have taken that. And yes, the answer remains the same for that you don't do fluid restriction. You'll have to give IV fluid. So there is fluid restriction does not stand as a chance in the inferior wall MI Ayub. I hope I'm clear with that. So JVP finding in severe TR, it would be CV waves. Now, this was a question that a lot of people got confused. I don't think there should have been any confusion. Confusion probably arise by a couple of students with the directly proportional and inversely proportional kind of a stuff. But remember that the inverse proportion will be the wall thickness. Direct proportion of the wall stress goes by the cavity pressure and the radius. So this was a question on Laplace law, very often asked. And this is about which of the following is correct for mRNAs. So options that were given were the eccentric hypertrophy in AS. Remember, in aortic stenosis, it is not eccentric. It's a pressure overload and it's a concentric hypertrophy. So that option was incorrect. A concentric hypertrophy in MR, again, that is incorrect because you have a volume overload, there is dilatation, and hence there is eccentric hypertrophy. So again, that option was incorrect. So what was correct? This was a question on Laplace law of how the hypertrophy develops in AS or AR or MS or MR because of volume versus pressure overload. So the stress or the wall stress, as it is called, in a chamber is directly proportional to the pressure in the chamber and its product with the radius of the chamber. And it is inversely proportional to thickness of the wall or the ventricular thickness, as we say. So ventricular thickness will go up in aortic stenosis. In patients with regurgitant lesions, it is the diameter or the radius of the chamber which increases. And that's how the wall stress is maintained in these conditions. So pressure increases in AS and hypertension, thickness, and hence the wall thickness increases, which is hypertrophy, to maintain the wall stress in these conditions. As the cavity dilates, the wall stress increases to maintain the cavity pressure. That's the principle of Laplace law. That's why the other two options were incorrect. And Laplace law's basic fundamental principle was the option that was correct, which is question number 9. Again, as I said, question 10, you can say nifedipine is everybody's drug. But again, cardiologists would stick around to it being their drug, what is the additional use of a cardiovascular drug? I think somebody's asking, sir, how many patients wrote SS? I'm not sure what the question is about. I'm not getting that question from you. So the drug of choice for acute mountain sickness, which is a high altitude pulmonary edema, the drug of choice would be nifedipine. In this option, steroids are the other thing that you can use. Remember, acetazolamide and beta-2 agonist are not so useful. Saurabh, thank you very much for sharing that the fourth option in the previous question, in this question was furosemide. So of course, diuretics don't do any miracle. Or what you need for high altitude pulmonary edema or even a acute mountain sickness is calcium channel blocker. That's what works. Steroid is something else that you can do. But remember, steroids are primarily used for cerebral edema. Steroids are not, even if the steroid was given as one of the option, you would still not choose that. It's the steroids work for cerebral edema, pulmonary edema. It's nifedipine, salmeterol, acetazolamide. All of them are primarily in prophylaxis rather than in treatment. So nifedipine, a cardiovascular drug, as I claim. This was a cardiac question, though it's a separate chapter, acute mountain sickness. The answer is nifedipine. Question 11 was asymptomatic female cyanosis, blue tongue. So cyanosis, again, I would say it's primarily a approach to a case of cyanosis kind of a question. It comes from general medicine. But again, methemoglobinemia is something that you would think of. Excess nitrates in water was one of the important option. And that's why the other options would not categorize, not shared or not discussed. But again, this was a straightforward question. Asymptomatic female and who's got cyanosis. One or the other thing that you must remember, if the echo is the other question is reframed, and it was asked if the ECG and echo is normal and patient is cyanosed with dyspnea in a child, you would suspect pulmonary AV fistula. So I believe that was not the option here. Patient was asymptomatic, so no dyspnea. Patient was asymptomatic, and hence this question of pulmonary AV fistula does not arise. Asymptomatic female, cyanosed, and patient, nothing mentioning about X-ray, ECG, or echo. So remember, if the question is slightly reframed, maybe in NEET SS, then you can look at the question properly if they are mentioning what is the X-ray ECG status. And if they say patient is symptomatic, no patient is cyanotic, not having pigmentary abnormalities, ECG X-ray is normal, the answer in that case would be a pulmonary AV fistula. Anticoagulant of choice in a patient undergoing angiography, angioplasty, in a patient having heparin-induced thrombocytopenia. Remember now, this is a tricky question. Heparin-induced thrombocytopenia, most of the times when you're not going in The drug of choice is fondaparinux. But remember, this is a deliberately asked question. Ashish is saying severe anemia was the option in patients with cyanosis. Remember, in severe anemia, you never get cyanosis because cyanosis happens when the absolute hemoglobin, reduced hemoglobin is more than 5%. So in a severe anemia, when hemoglobin is less than 5, there is not enough hemoglobin available to get oxygenated. So that's why actually severe anemia, despite severe hypoxia, will never develop cyanosis because reduced hemoglobin is never more than 5 grams because total hemoglobin is less than 5 grams. So good. Thank you, Ashish, very much for the sharing the other option. So this question 12, which we were asking, anticoagulant of choice in a patient undergoing angioplasty. Remember, the answer is bivalirudin. The reason is fondaparinux is known to be associated with higher incidence of catheter thrombosis. There is in the OSS trial, one of the trials which was done with fondaparinux, in the patient who underwent an intervention actually ended up with higher incidence of angioplasty catheter related thrombosis. So this was a bit tricky question. This is actually a DM cardiology level question. But remember, this problem is the reason why bivalirudin, which is now having good amount of data from a lot of trials to show not only safety, but also some amount of superiority in terms of bleeding event reduction. And hence, the patient who's got heparin-induced thrombocytopenia, if he is undergoing intervention, you go to bivalirudin. If not going intervention, plant conservative, you can stick still to fondaparinux. Saurabh is sharing the other options, which were low molecular weight heparin, but that does not hold true because we all know low molecular weight heparin can also have hit, though it is much rarer and lesser with unfractionated heparin. So the option if here was pretty clear. The answer would be bivalirudin. This was another question. Some people got really confused amongst the causes of aortic regurgitation, least commonly associated with AR. So I've given a summary slide of aortic root related causes of AR, which is root dilatation, ectasia, Marfan, Ehlers-Danlos loss, dissection, osteogenesis imperfecta, trauma, ankylosing, but you don't see any SLE here. So SLE does not cause aortic regurgitation. SLE causes is mentioned as one of the question. So Hari Prasad is correcting for the question 12 that the patient had undergone coronary angiography, which is again catheter related a procedure. So any patient who's undergoing an intervention in a patient who's got hit, you will have to choose bivalirudin and not fondaparinux. If you go in, if you intervene, if you put a catheter inside, if you want to take a picture inside, if you are going to cannulate, the risk of catheter which you are cannulating, whether for diagnostic procedure or a therapeutic procedure, can develop thrombosis on patients if they are on fondaparinux. So don't choose fondaparinux if you're intending to catheterize. So the option there becomes bivalirudin. So thank you, Hari Prasad. That's why I said this was a tricky question. They may confuse you just mentioning angiography or only angioplasty or either. But if you go in, the drug of choice is bivalirudin, not fondaparinux. So least commonly associated AR amongst aortic dissection, Marfan's and ankylosing, all can develop. SLE can cause a patient to develop mitral stenosis, aortic stenosis, but not aortic regurgitation. So Garvit has mentioned it was coronary arteriography to be precise for the question number 12. But again, as I said, it doesn't change. If you go in, you have to go off fondaparinux. So question 13 answer, I believe, is correct. Everybody got it now correctly. The answer was SLE. Question 14, this was a good question. They actually looked at, incidence kind of a thing, a factual question. Asymptomatic 30-year-old male, no family history of sudden death. Now that, when no sudden death, you're ruling out other syndromic Brugada, you're ruling out epsilons. So that's the important thing. Some ECG abnormality, ACO TMT normal, that's fine. Most likely ECG. Remember, the incidence of RBBB alone is 0.2%. Compare this with Brugada, which is around 1 in 500, which is like 0.2%. So if you go by the frequency of the abnormalities, Brugada happens in 0.2%. That's the incidence. RBBB alone as a conduction abnormality in a 30-year-old male, likelihood is around 0.5%. Now, they've made it tricky, though. If they had put it, as a 60-year-old, the question was very easy. If they said a 60-year-old male comes with no history, sudden abnormality, and echo TMT normal, then you would have thought of RBBB as a straightforward question. Now, if when they mention 30-year, because you must remember that the incidence of Brugada is not so uncommon in our part of the world. It's 1 in 500, which is 0.2%, and RBBB incidence is 0.5%. So I just had to actually go through the review of literature, and then that's how I arrived at this. So RBB occurs in 0.5% alone. RBBB epsilon occurs in 0.2%. RBBB, the ST elevation, other options are ruled out. So confusion was between epsilon wave and RBBB alone. And the answer would be RBBB alone, because 0.5% and 0.2, most of you marked 0.5, but you probably would have missed the complexity around it, which is good enough, because you still got it right, because the difference was very narrow between 0.5 and 0.2%. So but I think if you have marked RBBB alone, that's the right answer, if the question was exactly the way it's been recalled by all of you. There was an ECG on sine wave, which everybody probably got it right. Sine wave appearance is seen in. I don't think this was an image question. You can share with me whether was it an image question, or was it just a factual question? Was it just a text question? Sine wave appearance is seen in. So a sine wave appearance is seen in hyperkalemia. No question of hypothermia, where you don't see, you do see Osborne waves, but you don't see sine wave, hypocalcemia, etc. So Saurabh is asking, if the question had positive family history, yes, then it would be Brugada. Saurabh, you're right. And that's what I'm saying. This question number 14 was not so simple as it probably looked like, and probably everybody got it right. The question was actually a bit tricky. If they change anything here, if they make it 60 years, then it's absolutely RBBB. But if you change it to family history positive, it becomes then it becomes epsilon. Then the incidence is much more, symptomatic wise. If you change it to any other thing, again it becomes a bit tricky. So why was he subjected to TMT? Because he had an RBBB. That's why. So ideally, just to evaluate for ischemia, that's probably they did it. So again, that's the point. Ayub, you're right. I mean, they are probably looking at development of STT changes in a patient of Brugada syndrome, whether they are brought out. That's one option. That's something that needs to be seen. But TMT normal would not tell you. I mean, if they were saying Brugada, they would say that the TMT worsened the changes that were there on the baseline. That was not mentioned. So either that should be mentioned. When you say TMT is normal, that means it's probably not Brugada. Exercise should actually be bringing it out, in some of the patients at least. So when they are mentioning like this, you would be more tempted to answer RBBB. But this question more complex, Dr. Ayub, than probably it looks like. And I would go around with RBBB only rather than with the epsilon wave. Other option that was given in sine wave, Arghya Chakravarti is saying is morphine. And Ayub is saying this was purely just a text question. So is Deepa. So this was just a text question. There was no image, but I've added an image for you to understand what you mean by sine wave. This is what you mean by sine wave. This is how it looks like. And of course, everybody probably got it right. Thank you, Deepa, for sharing that. It was just a text question. Thank you, Ashish and Ayub and Aragya, for your inputs as well. There was another question, again, a bit tricky, on the various waveforms on ECG. Again, probably a text question only. And they were asking about all the waveforms. So P wave is only LA activation, we know. Of course not. When you have the SA node itself in the RA, how can it be only LA activation? You know that the initial part of the P wave is the RA, later part of the P wave is the LA, and that's why you get P pulmonale and biatrial enlargement and P mitral and mitral stenosis, etc. How the pathophysiology, how they develop, how they look differently. You can go through our ECG lecture, which is there even for MD medicines that we have created now, why the P waves are tall and peaked in P pulmonale and bifid in P mitral. So it's not LA activation. The other option was U wave is seen as tachycardia. Actually, it's seen more in hypokalemia, brought out more by bradycardia. So that again is incorrect. So yes, Srinivasa is saying that the options were hyperkalemia, hypokalemia, hypercalcemia, and hypercalcemia for the question number 15 that I discussed. So fair enough. T wave is atrial repolarization is what Saurabh is saying. But most of the students that have shared me, atrial repolarization. So yeah, that's fine. Either way, T wave is ventricular repolarization, though that option was incorrect. So it is repolarization. Yes, the fourth option is repolarization of T wave. So that means it's incorrect option, right? Because we all know that the atrial repolarization is actually submerged in the QRS complex, and hence it is not visible on ECG. So that option is also incorrect. So only option that's correct is the J point. J point elevation can be physiological and pathological. It is seen in hypothermia. That is the right option. So J point elevation is what we classically see. Physiologically, it can happen, and pathologically, you see it in hypothermia. That's part of the Osborne waves, which is the right option. And we remember, and we did the recall on the Osborne waves as well. So again, this was a lot of questions were there in the recalls and the important topics that we did from our couple of sessions. This is my favorite. I felt so happy about this question. I think I was the only one who discussed Carpentier classification in the recall sessions. And I was, binging upon this. Probably something may come around. And it did. I'm so glad. For the other questions, I'm not so happy because Carpentier, I was not very sure that somebody will be asking it, and they did. So the Carpentier classification, MVP is associated with what Carpentier classification type, and it is type 2. And I think, again, I'm repeating the slide from our quick revision session. This is what we had discussed: type 1, type 2, type 3A, 3B. So in the QRP session, we had discussed that type 2, it's the reflex prolapse. When the type 1 is normal, type 2, so type 1 is out. You normal, so you cannot have. Carpentier 1 is normal, where the leaflets are okay, only annular dilatation is there, so that you get in dilated cardiomyopathy. But in the increased leaflets, you have myxometer degeneration, caudal elongation, caudal rupture, papillary muscle elongation, papillary rupture. This you find, as they've mentioned here, in degenerative, fibroelastic, Marfan's, Barlow's, from Froste Barlow, which is nothing but MVP, right? So endocarditis, trauma, ischemic, Ehlers-Danlos, etc. So answer is type 2, because we all know in MVP you have increased leaflet motion as well as prolapse. If it is restricted, then you call it type 3, again, which is of two types, A and B, when there is restricted opening or restricted closure. So this was from our QRP, and the answer was 2. And I'm glad that my session helped, and a lot of you guys got it right. Everybody got it right that it was class 2. So myxomatous degeneration was mentioned for the mitral valve. So again, that includes here as the type 2. So it was not MVP. Saurabh is correcting. It was myxomatous degeneration, again, which goes, as I discussed and shared, it is type 2. So myxomatous degeneration of in the Carpentier would fall into type 2 of Carpentier classification. Question 18, relative bradycardia, you may call it ID question, but bradycardia, relative bradycardia, or also called asked as Faggot sign, is nothing but what is classically seen in enteric fever. So as we know, for every degree rise in temperature beyond 100, heart rate should increase by 10. If it increases by less than 10, it is called as relative bradycardia. I don't even need to be sharing other options here with you. Some of the other causes are, of course, encephalitis and yellow fever, etc., etc. But if you have enteric as an option, this we've been learning from undergraduate. This is an undergraduate question. You classically see relative bradycardia in enteric fever. So, if there are even the options are given as yellow fever, meningitis, or cholecystitis, I would still stick around with enteric fever as the right option. Least common cause of heart block, or probably they would ask for a complete CHB as a complete congenital, or was it simply as a heart block? Whatever it was put, remember HIV hardly ever causes it unless it's complicated by a secondary infection or secondary etiology. Lyme's, Chagas, and diphtheria. All three are known etiologies, some of them temporary, some of them permanent. Usually, most of them are temporary. When you treat diphtheric myocarditis or Chagas disease or Lyme's disease, a lot of these patients would recover. They don't require end up with a permanent pacemaker. You need to tide over the crisis with a temporary pacemaker. And once you're done with it, you can actually have a reversible treated with the drugs and steroids. These patients will not require a permanent pacemaker. So sometimes this again was from our question bank. If you remember, we did not mention it. The question framing was a bit different. We had framed the question like the Lyme's disease patients require permanent pacemaker. That was the one of the option which was incorrect. And there we had mentioned that multiple disorders actually require pacemaker, but you don't require a permanent pacemaker in Lyme's or Chagas disease. So the option here was HIV. So you don't get complete heart blocks or heart blocks in patients with HIV. This was a question that a lot of people got confused. Which of the following is a which of the following is a class 3 agent? Excuse me for the 4 that is typed in Roman. Which is a class 3 agent? IV, sorry. So that was IV. I was told by some people that it was mentioned as an IV, and that's why people got confused between amiodarone and abutolide. So which is the following is intravenous class 3 agent with potassium channel blocker which inhibits the sodium channel inactivation? A lot of people actually recalled the question incorrectly also, I was told, but then some of you actually helped me out with the right recall, and then it was pretty easy to understand. On the right side, I've given you the options. You can see that amiodarone and ibutolide, both are IV drugs. We know that. Dronedarone, ranolazine are not. So we know that amiodarone decreases phase 4 slope and conduction velocities, but it does not have much impact on the sodium channel inhibition of the sodium channel inactivation. It's the ibutolide, the slow inward sodium activator, which delays the repolarization, inhibits the sodium channel activation, which increases ERP, and it is used IV only. So that was pretty much the framing of the question, which substitutes and falls into the category. Sotalol or dronedarone, etc., would not fall into this category. So these are the drugs and their therapeutic usages. If you go through, the option was ibutolide. So Ayub is saying that the question was only IV potassium channel blocker with late sodium inhibitor. That's what I'm saying. So inhibits the late sodium inactivation, which is sodium inhibitor. So you don't get that with any other drug. So I think with that option, you would have to choose ibutolide. So there were a couple of more questions, but I'm not sure whether you will consider them as into pure cardiology. I think one question was, I was told about acute hypoxia pulmonary edema management, and the treatment option would be CPAP. Bifascicular bath with first degree heart block, somebody was saying, but the person was not able to recollect the option. I believe if there was an option on high grade AV block, then that's what it would fall into, or maybe it was an ECG that people were talking about. Erythromycin, which was used in rheumatic prophylaxis, but it also is a motilin agonist. Dupuytren's contracture, you can, of course, you do get in cirrhosis. This is one of the recalls that people shared with me as an image question, so I thought I'll put it here as well. And there was some core pulmonale question with the TR and JVP, which again was the other question than the TR that could have fallen into. So all in all, I would say roughly there were 25 questions that were there from cardiology, which is like 1 in every 6 question was cardiology. So I would say instead of 12 subjects that we have, cardiology is still dominated it twice than it would be. So that is the session that I wanted to discuss for with regards to the cardiology recall. Thank you. And I'll be connecting with you for the detailed discussion, maybe on the app with the explanations if required. But I think we have discussed primarily all the important topics related insights as to why the option that was assumed to be correct, why they were correct options. So we have given the explanations for them, and there'll be more recall sessions coming up for various specialities. We are doing that for ID. We have another one for gastro today. So we have the important sessions on the recall sessions lined up today. So stay connected with me, and it'll always be a pleasure to help you out and discuss out and guide you in whatever other ways that I can, including your branch and college selections. If I can also guide you personally, you can text me and get connected to me. It'll be a pleasure. Thank you very much. Thank you for subscribing and being connected with us. Good night. Goodbye. Take care. Bye-bye.